Welcome. This is Barbara Brandt, Director of the National Center for Interprofessional Practice and Education at the University of Minnesota. Today we are hosting the second webinar in a series on the Accelerating Initiative, which is the Accelerating Interprofessional Community-Based Education and Practice, which was funded by 4 private foundations: the Robert Wood Johnson Foundation, Josiah Macy Jr. Foundation, Gordon and Betty Moore Foundation, and the John A. Hartford Foundation. Today's topic, you will be conversing with the University of Nebraska Medical Center team, and the title of their presentation is Nexus Success in Nebraska, Invested Leaders and True Partnership. So our Nebraska team today who will be presenting is Claudia Chaperone, who's a faculty member in the UNMC College of Nursing, Rebecca Wester, who is a faculty member in the College of Medicine, and a geriatrician who is the medical director at Ambassador Health Skilled Nursing Facility in Omaha, and Linda Sobeski, who is a faculty member at the University of Nebraska Medical Center College of Pharmacy. I will be a facilitator, actually an eager participant listening to the team, along with Carla Dieter, who is the coordinator of the Accelerating Initiative programs and also the coordinator of Nexus IPE programs, which extends beyond this initiative. This is our disclosure slide, which is because there is jointly accredited accreditation available for participants, and we have no disclosures of conflicts of anybody on the team presenting today. So Carla, you want to talk about the objectives for the day?
Yes. So this webinar, as well as every webinar in our series, is to really highlight the Nexus IPE team and how they were able to implement an academic practice partnership, which we call the Nexus. They're going to be describing how their team of students and health professionals actively learned and worked together with people to improve health and well-being in the community. They're going to be also discussing key lessons they learned from the Nexus IPE teamwork and describe the application of at least one Nexus IPE learning system tool. And the tool that they're going to be describing today and letting you know how that has supported their success is the Compelling Vision tool. Next. So as Barbara said, there were 4 private foundations that came together in 2016 to partner with the National Center to fund 16 schools of nursing with graduate programs to form academic community partnerships. And the premise was really based on the 2010 IOM Future of Nursing report, highlighting the need for interprofessional education in settings other than acute care. So these 16 schools came together. There was a 2-year cohort. They received $50,000 plus significant technical assistance from the National Center for 2 years, and many are continuing on with us still as we go forward. The sites also needed to match a $50,000, and that we assisted them with a New Models Institute, many tools. Each site got one site visit and affinity call groups. And then we also had an external evaluator with Harder & Company who was able to evaluate their progress and what we learned throughout those 2 years. For more information, please visit nexusipe.org. And many of this there's a link right on that front page to the Advancing and Accelerating site. Barbara?
Just to reiterate, we did do a presentation a couple of weeks ago, and the webinar is archived on that website. I have to tell you, we're having a little bit of problem with the slides, which you might note. We'll try to make it as easy as possible. So this is the webinar in one slide. So we advocate that the future is interprofessional. The key is a focus on community and practice. In our work, we design interprofessional education in the community around people and families and communities and populations, not professionals and students. That'll be a story you hear today. What is different is that we believe that you can redesign both healthcare education and healthcare delivery simultaneously to be better integrated and more interprofessional while demonstrating outcomes. And that certainly will be the story you hear today. We also believe that we should be training and educating students to add value to authentic clinical environments, and that students and health professionals can learn and work together to achieve outcomes. And the outcomes that the team today will be talking about is that ultimately all partners are meeting their goals, learning outcomes, and health outcomes. And you'll hear from them key lessons that treating partners as equals, securing commitments from leadership, and the leaders were certainly on board with this project, identify clear lines of responsibility, and as Carla mentioned, creating and communicating your compelling vision is the tool that they will be discussing. Before I turn it over to the team, I always start every presentation with the World Health Organization definition of interprofessional education. It occurs when two or more professions learn with, about, and from each other to enable effective collaboration and improve health outcomes. So that will be the journey you hear today. And I've already given you the call to action about redesigning healthcare education and practice together. So with that, I will turn over the rest of the seminar, the webinar, to the Nebraska team. Claudia?
Thank you very much. I'm very pleased to present the Nebraska NEXUS, the Comprehensive Geriatric Assessment Program, and that was for interprofessional practice and education. This is our lovely campus. We're happy for a moment to show you this. Many beautiful things going on to enhance and teach interprofessional education here. We're invited to focus our presentation on our experience of creating our vision. You know, our context, who are the people, families, what population. And actually, we're a good example to present that information. There is a huge need for the area that we're interested in for us to improve practice. We're concerned as a gathering body here of partners that there's almost a crime being committed against the older adults being transferred from acute care into primary, especially in the skilled nursing facilities. The issue has to do with communication, problems with interprofessional education practice so that people are able to do this safely and to be very patient-centered. When we wrote our first grant, we had the information from the Inspector General, and it was saying that 33% of skilled nursing facility Medicare beneficiaries were experiencing adverse events and injuries, and that really a third of these were medication errors, and it was costing the system at that time in 2016 $2.8 million. And I wish I could tell you that has been improved. It is not yet solved. So we feel more and then a little bit empowered to continue to work on this problem. When we were putting this together, we found out that we had a physician champion we didn't know about. I gave her about 20 minutes to decide. We'd already had 2 meetings working on our proposal. So one of the staff members in the facility said, Claudia, you've got to call Dr. Rebecca Wester. She's working hard on problems with transition from acute care to nursing homes, and she would really be good. So I thought, well, I'm very sorry, I didn't know that. Called up at her office, talked to her secretary. She said, well, I'll ask her, but the next meeting is only about 40 minutes away. I said, that's fine, you just tell her and we'll get with her if she can't come. 5 minutes later, she says, the lady talked to me, she said, well, she's coming and she will be there at 2 o'clock. I said, well, here's the room number, how to get in. And she just really has been like our guide through this, because the problem in healthcare is so much. It takes a whole team of people, and I would like her very much to share some of her knowledge about why this was and still is a problem.
Thank you. Hospitals are discharging faster and sicker into the skilled nursing facilities in order for the patient to recuperate after acute illness, whether it's pneumonia or a stroke or even a hip fracture. The level of care that used to be at the hospital is now being cared for at the nursing home. And the nursing home level of care of once was, is now being cared in the home or the assisted living. As a geriatrician, it's more than about decreasing 30-day readmission rates. It's about the well-being and maximizing function and treating the whole person. As a certified medical director, I achieve blending the long-term care nursing home policies and regulation with medical interventions. Just in the last month, there's a new payment systems in all the nursing homes, and that impacts what we can do as providers in medical care. Vulnerable seniors are frail and they lack the reserve to weather the polypharmacy or whatever issues is going on, and most don't bounce back to their prior level of independence at home. It's all about the patient. Some hospital systems look at the medication error rate as an unfortunate statistic, but it could be the difference between walking out of a nursing home or a hospice referral. Teaching where this top 1% sickest of the sick population lives in the nursing home, assisted living, or during their transition of care during skilled nursing, that's where it's at. What could be better?
Thank you. That's a very good indicator of just how important she is on our team. If you don't know about working in skilled nursing facilities, especially the ones that we desire to help, the dually certified nursing homes, which means they are Medicare, Medicaid, and these are the sickest of the sick, and they are also the ones that need our help the most, and that's where our mission is accomplished. We are very interested in that. I would like now to talk about the alignment of Nexus IPE program and academic community partnerships. I'm going to begin talking about this while we get our slide. It's simple. In order for us to really be a part of the National Center for Interprofessional Practice and Education, we really needed to work to build our academic community partnerships. We began where the heart of this is in the community where Dr. Wester and I are working as providers, but we needed to use the guidelines from our compelling vision and that which we were being taught by the National Center's experts to develop an academic community partnership to go that one step further. And it started here at the University of Nebraska Medical Center. And when we were writing our proposal, we worked with the College of Pharmacy because the biggest problem for us that we felt we needed to achieve was to resolve the problems with these medications. And when you do interprofessional, I mean that we use every single person that we have on hand to do this to the best of our ability to make sure our patient does not have those negative outcomes that are reported by the Surgeon General. So at the University of Nebraska Medical Center, we have the wonderful people from the College of Pharmacy, and especially the person with me today, Dr. Linda Sabesky. We most importantly want to thank and remember that Our dean here at the College of Nursing has continued to sustain us after the funding is over. That is Dr. Julianne Sebastian. She is our champion. And again, you know, you need to have top leadership to really be in your corner. And Dr. Dilly Davies is our vice chancellor, and he is unbelievably devoted to things of IPE all across the system, but he has been just so very supportive of this program. I think if you're trying to do this, you need to have that kind of leadership. The two partners in the community cannot be forgotten, because this is difficult to do in skilled nursing, and they were invested. You see, when we talk about it in a meeting, we're talking about data, we're talking about our partners, students, whatever. But out in the real world where this is happening, all you have to say is you're going to try to do something that makes it safer and have a better quality of care for people that are admitted to skilled nursing. And they immediately say, well, where do we meet? What time? We'll be there. Just as Dr. Wester said, you know, oh, I'll be there at 2 o'clock, no problem. And that's pretty much how it's been. I love to hear all the wonderful things that we've learned about how to use an elevator speech to talk to people about how we're going to have a good, compelling vision communicated to others. But all you have to do is tell what the reason for the compelling vision is. And these two facilities stood up. And they both contributed. The owner of Ambassador Health Corporation, Mr. Timothy Julis, heard about this, and we said, we just need some more money to make our $50,000. He said, I'm going to give you $50,000, and I would invest in this if you weren't participating in my nursing facility. This is a critical need. And Azria Health Midtown have lots of Medicaid patients, and they said the same thing. And what they did is provided money for their employees to come to that first challenge where we went to the Interprofessional Education Center and were trained on how to do the things they're trying to implement. Nebraska Action Coalition here in Nebraska, they are very, very positive about the future of nursing and leadership, and they were also contributors to this particular activity. Next slide. So forming practice partnerships more in depth, PI and certified medical director had a vested interest in both partners in the community. Both partners recognized the need and they were with us. Community partners had a trusting relationship. And this is something that we will stress a little more. We tend as faculty to come out and do something and leave. That cannot be if you're going to do anything that's sustainable in a system. You have to have a commitment. You have to be accountable that this is not going to just walk in and leave. There are also pre-existing commitments across the board with other partners. So with this, we talk about the successful model that we're going to talk about. And this is a very short, accelerated program, and we were told that in order to propose and apply for this grant that we had to have a practice already in place. I told you about the wonderful warm place we have to do our practice, but initially we were talking about this rural mobile nurse practitioner-led managed comprehensive geriatric assessment clinic. And I just want you to know that it's unusual for nurse practitioners to lead on any kind of a, what we call a CGAP, comprehensive geriatric assessment. We'll talk more about that in a little bit. So the next thing that we did was we were doing the Nexus IPE tool, which is our compelling vision. Why is that important? We have to know where you're going. I know that sounds trivial, but let's just face it, we have so many components of doing an interprofessional education program that we think about our students, we think about our partners, what they need from us. But you need to remember from the beginning and keep everyone focused on the fact what we're here for is that we have a very serious problem of potential harm to patients coming from acute care into skilled nursing. And we need to focus on these patients and their families and what that's going to do for them as they go back out into the community after their stay in the skilled facility. We are very interested in keeping in close contact with the triple aim alignment, moving towards a quadruple aim. And I just explained that is a very important concept. We're interested in the patient's experience of their health care. We're looking at this from a population health perspective. You know, are these determinants of health? What is going on with us that we might be a vector to reduce costs? And also, we don't forget the fact that we and the staff in the facility and all of the college helpers, we need to maintain the team well-being. And I know that Dr. Wester reported that when we were in the heat of this, we saw a decrease in people leaving employment. And in long-term care, if we can keep people invested and decrease the amount of turnover, this is huge. So the applied outcome measures are both academic and community, but most importantly, I do not perceive that we have done anything to improve interprofessional practice and education until we show that we can make a difference in the patient outcomes. And we'll continue. So creating and communicating is something that we really had a lot of excellent leadership from the National Center. And this is something that you don't do in your day-to-day work, and you need someone from outside to really help you to communicate up the channel to your leaders and all the way out into the community for people that you want to invest in your program. We are a campus community. We are totally together on this. It isn't that we wrote the proposal. Our engaged partners were sitting at the table. We wrote it together. We worked on how we would work together to empower our patients to engage with us, that they would buy into this and be a part of the collaborative partnership. They were really ill. They had many complex medical problems. Many of them were delirious on medications, or they had cognitive issues prior to ever being sick. We know this population. So we have mutual continuous learning going on all across our partners, our students, everything. The one thing that's interesting is that the students, the patient residents, the clinicians, we really meshed. I can't explain to an outsider how invested. I think that the nursing home personnel were so overjoyed to be, like they're kind of in charge. They got something good to share, and they're going to help these students learn. It was wonderful. So we have improvement of collaborative competencies. What's that mean? Well, adult general primary care and geriatrics and all that. We have competencies that we need on interprofessional practice, but we also have competencies on geriatrics. And we'll talk more about that. We'll keep going. So when we get involved with Nexus IPE, it really changed the game. We knew how to do a comprehensive geriatric assessment, and we are a little embarrassed sometimes because a lot of people in the Midwest, especially at University of Nebraska Medical Center, know a lot about doing this. This is not due to them, but I'm informed that it is different around the United States. Our stakeholders, they knew what they wanted, they knew what it was, and they were involved. We knew the critical need. We understood that the Nexus IPE program needed to align with all of the organizations. And that's something really important. Our vision, the missions of our partners, especially the National Center, we were one in mind. And we identified goals and outcomes together. We had big ideas, but you know what? Our particular operation was very small. The compelling vision that we have is bringing together a community campus that I have described for you. And our most important thing is we want to stop this problem. We want to assure older adults they are duly Medicare and Medicaid certified, and that means that they are the most needy and they are using most of our Medicare dollars too. We want to make that change for them, improve their health, well-being, and daily functioning. It does actually prevent readmissions, hospitalizations, and reduce costs, but that isn't our goal. So we're going to talk about the grassroots operation. This is where it happens. This is the most important group. I'm sorry, leaders, but if you're going to make this happen, these are the main leaders that are going to make it happen. We had strong nursing leaders in these facilities, They were invested. Dr. Wester, you heard her speak about the problem and as a certified medical director, what she wanted to accomplish. I am a teacher and a provider. I'm totally into this. And Dr. Sebeski is a champion. Keep going. The Gerald Competent team. I think it's important. I want everyone to invest in this. But in order to really do the team I'm going to describe to you, you've got to have knowledgeable people. There's lots of ways you can get knowledge. But one of the things that we want to talk about, Dr. Sebeski and I, is about education. Adult general advanced practice registered nurses know more about this than other types. Not that we don't want to invite our helpers in and teach them. They're right here too. The Gerald Competent pharmacist is critically needed. We have to have this very knowledgeable medical director in long-term care, and the staff were already excellent, and they really did benefit from more education. I want Dr. Sebeski to go and expand on this for us, because I think the medication optimization is a lot different than medication reconciliation. It requires her expertise.
So inappropriate medications are really those medications where the potential risks outweigh the potential benefits for an individual patient, and it's very individualized. What's inappropriate in one patient is not necessarily inappropriate in another. And this can occur when providers, regardless of their background or training, are unfamiliar with what appropriate prescribing looks like in an older population, or what the particular susceptibilities to medications occur within the elderly population. Or sometimes providers are aware or familiar with some of the inappropriate medication criteria, like the beers and the stop and start, but there's a sort of a resistance to making change. And that may be because the patient is highly emotionally invested in a particular medication. It may be because the physician is uncomfortable sort of rocking the boat if the patient's doing okay. Or lots of times the answer is, I didn't prescribe it, so I'm not going to stop it. So the optimization of medication is really a patient-centered approach, whereby medication therapy is systematically reviewed for drug-related problems, and then interventions are made, or recommendations for interventions are made by the pharmacist to the provider that are based on realistic patient-centered goals. And these goals are mutually determined by the providers and the patients. Care transitions in and of themselves are very high risk for medication errors, and as Dr. Chaperone mentioned, this especially happens when communication is poor and we're not really talking to each other. Even the Joint Commission recognizes this, and they've mandated medication reconciliation for hospital transitions. Comprehensive geriatric assessment at the time of a healthcare transition really allows the healthcare partners to, and in particular the pharmacist, to help correct the inaccuracies in medication prescribing, as well as look at that optimization piece where we're getting the not just the right drug. Is it correct according to how it was prescribed, but is it right for the patient? Is it the right drug? Is it the right dose? And are we monitoring it appropriately?
I want to go next to talk a little bit. You see how strong this partnership is, but let me talk about this from the National Center's perspective applied to our Nexus. I think the thing that was most inspiring, and I was so happy to be invited to be a part of the National Center National Center for Interprofessional Practice and Education, because if you've ever experienced a team that has this transformational interprofessional set of behaviors, it's kind of like everybody ought to do this. And this cogwheel is sort of a way for a sort of a picture about how this should work. So, our team is so cohesive and trusting. Just like Dr. Wester I gave her 30 minutes and she came to a meeting. She's invested. So the relationship between her and I was immediately sealed. I know she is trying to help. She helped us get the $50,000. We had a short time. We work That relationship is focused on what the patient needs, and we're going to all work together. The communication is greatly enhanced, and we worked on that communication a great deal while we were doing this. The first thing we did is Dr. Carol Geary, who is a faculty in the College of Medicine right now. We'd like to change that someday. She helped us with her expertise in evaluating systems and work situations we did focus groups on all of these nursing home personnel to see how they communicated. How did that teamness work? Were they cohesive? Did they trust each other? How do they manage conflict? And the results on that were just fascinating. But the one thing that came out of that is that they have a lot of turnover, and yet they can come together in a crisis and really work as a very trusting, cohesive team. And with the verbiage that we heard in the qualitative analysis by Dr. Geary, indicated that they do something I've come to like to call intentional teamness. So if you teach them how, they are going to get together and go in a crisis, and they do, and they're proud of that. The team goal is the focus, and it isn't so much that you each write a care plan. There's a huge team of people that work on every admission. Therapies, social services, administration, primary providers, et cetera, et cetera. It's a large process. But when you do this interprofessional teamness, there's one care plan. And everybody communicates, and we know what each other's doing. And what that promotes with a little practice is what I call a very high functioning team. If I am not there and I've written a discharge plan and somebody's calling in, they don't say, oh, well, I didn't know anything about that. That they would know about that. So the cogwheels explain it best. We have variable leadership. That means that if you didn't notice, Dr. Sabuski has a great deal of knowledge. When she gets her leader hat on and speaks to me about something that we were going to do related to a medication change, I listen. She knows that medication very well. We really work to improve trust and cohesive behavior, and at all times we don't forget our goal about serving the patient. I'm going to now talk about the stepwise journey, and I'm not going to talk about all of this. I would just say that we started in 2016 and 17. We did our development and planning phase. We did a lot of evaluation, more than just the focus group. We tested for culture safety. We looked at team steps to see how they were doing. We tailored everything so that the teams, the students, everyone had a chance. One of the things that's unique about the way we teach at UNMC is our hybrid program, and we really do work on making sure the students lead on writing a lot of the content for this. If we're going to have an interprofessional e-learning module, but we had a select group of students that actually were very active leading and preparing that. And the goal for that is they're getting ready to lead on an interprofessional comprehensive geriatric assessment. We have a new model that we created with the National Center. We're talking about intentionality in our education. We're trying to clarify and operationalize our compelling vision. So when we go to measure our outcomes, we have something to tell the world. Another thing to know is that we get, nursing homes have a very bad reputation. They tend to, ain't it awful? Well, we didn't select inner city, dually certified facilities that were in trouble. These two facilities are actually high performers, and they get a star rating at their time of evaluation by the state. And they were both varying over the 3 years, a 4 or 5 star. And usually the infractions had something to do with some other department, not the nursing or the therapies. I want to talk a little about learning in an authentic clinical community. And before we start, I'd like to invite Dr. Sabuski to begin to talk about teaching within a CGAP with that as a model of education. Could you kind of begin that conversation for me?
So our pharmacy students during their third year kind of get several weeks of geriatric pharmacy or geriatric pharmacology. And we have lots of multiple opportunities to use cases and patient simulations. And these are students who've not yet progressed onto like a practical or practicum type intervention. And so this really provided a unique opportunity for our students to one-on-one deal with providers and deal with patients and deal with a true live model for education. The pharmacists and the students were divided into teams, and we had several teams working at different facilities with different patients, and it wasn't easy to bring everybody together. And you know, you talk about people being on board for the project, and that was probably the easy part, coordinating between two different learning programs and trying to put everybody together and in the same spot at the same time, given their various other, you know, commitments, was certainly a challenge. But we made it happen, and each team went out there with their faculty leaders and were collaborating to essentially review the patients, interview the patients, create an H&P, a problem list, and then a set of admission medication treatment orders that were optimally designed to benefit that patient given their medical conditions, their prognosis, their functional status at the time. And then we went together and after the students developed their plans, and Dr. Chaperone and I sort of staffed the plans and got and gave the students feedback and used that kind of as a learning opportunity. The students, it was interesting, were kind of reluctant to interact with each other at first. I know in at least one group we had students where the nursing students were sitting together and the pharmacy students were sitting together, and I could see that they were faced not toward each other, but within their little groups. And so we had to do a fair amount of nudging to get the students to interact with each other. In fact, I made them sit every other discipline, so that they would have to talk over each other to talk to their co-discipline partner. So it really it ended up being a fantastic opportunity for the students as far as training. And they got to deal in a real live environment, and I think that was very, very transformational for them.
I would like to talk a little bit about how we use the comprehensive geriatric assessment model to prepare the students and then to work with a patient. In the morning part of that session, the adult general nurse practitioners, and some of them are primary provider trainees and others are acute care trainees. There are two kinds of adult general students. And for any faculty that might be listening, the adult general competencies for both of those sections ask for content that relates to all of the components of the CGAP. And so it's very nice because we can include this as part of our competency-based objectives in our courses. And this really helps with parceling out how we would get this accomplished. And just to look at this for a minute, we are very interested in these very complex medical problems. The students do a lot of clinic, just as in pharmacy, they're doing a lot of clinical problem-based cases to get ready. They learn how to evaluate functional status, what kinds of interventions they have at their hands, and cognitive status, and all of those things. The one thing for you to know is at the same time these students are being trained, all of this is training going on in the facility at the same time. We are really working with them. They're taking many of the same e-learning modules, much of the team steps re-taught again. One or two person process, no. Lots of team members learning at the same time. There's a large MDS3, which is a comprehensive list of things, 20-some pages long. And the thing that's nice about that is when you're measuring outcomes, they now do very comprehensive G codes. So we know function from day one until the last day that we check out. Just a couple comments. We're going to run out of time, and I want to be timely for Dr. Brandt and Dr. Dieter to talk. We did measure our outcomes. We were very small in number, but our scores on this feasibility in 2019 were very promising. The ICCAS showed significant improvement, especially in the students' collaborative abilities. And this is interesting because both Dr. Sobeski and I have been teaching them semester after semester, and what we asked them to measure their learning was from when they really knew what they were doing until the end of this CGAP experience. And look at this, they went up very much in that short assignment. So the medication changes were very hopeful. They improved by decreasing overall medications. The PINs was not significant, but it was hopeful. We were hoping to see that. Part of the problem with potentially inappropriate medications when you're doing a short, 30-day evaluation period is you don't even have them all removed to know what's going on. You might have some dose decreases. A lot of these can't be cold turkey ended, and so we didn't have good outcomes on that. But I just want you to know that we were basing our hopefulness on the mobile nurse managed clinic results, and those patients had very significant improvement in the number of Beers List meds decreased at 8 weeks. See, that's a longer period of time, and those were very significant. The patients were 57 in number instead of small like we have, and there were also decreases in doses that were significant and many different changes along with the medications. We know that this will work if we have a larger student population and patients, especially a larger population for our patients. And one last final thing, and I will end, and that is that we were looking for how did the patient experience this? That's very important, the quadruple aim. And here's what I have to say to you. This happened on the bus, but not quite as much as it did in this setting. They're so afraid when they come out of that hospital. They're not themselves. They're really pretty acutely ill still. You can't be in the hospital 4 days and think you're going to be really in control of everything when you're moved. It happens quickly. And they didn't maybe think they really had much control over where they went. It went so quickly. So when they start out and we do our qualitative interview with them coming in, they'll say, I just didn't have any control. They didn't tell me what was going on. The hospital said I had to go and gave me hardly any choices. And here I am, and I'm just, helpless and loneliness and lost. But after the CGAP, we really had some wonderful things. What one patient said that pretty well sums it up. Things are going quite a bit better, 2 thumbs up. Well, actually 200% better. I really feel in control of my care. And that's pretty much the Nexus from Nebraska. We do have some discussion, but let's pass on to our learned leaders. Dr. Brandt?
Actually, Claudia, why don't you go ahead and finish your presentation? That would be,
I will.
Yeah, go ahead. You've got time, and we do have a couple questions coming in. So after you finish this, I will make some observations and then take some questions. So anybody on the webinar can set us any questions. Go ahead.
Okay, 2019, we really had finally, you don't do this and it works the first time. In case you're trying this, it doesn't work the first time. I would have to take ownership for 2018 that I alienated all my colleagues because it was very hard to follow how to do the measures, and we got better. So in 2019, we did our feasibility study, and we were looking at this preliminary data, and it really was suggesting improvements in IPE competency in our students. And the ICCAS tool is very reliable and valid. Plus, we could see that there were trends that were similar to what we could do that was measurable, was enough sample and so forth with patients, that we can make that difference in reducing potentially inappropriate medications. And right now, when we finish this, I was a little bit disappointed because we don't really have enough data to estimate effect sizes or really to test everything. But we really think this mirrors what we learned doing the mobile nurse managed clinic. And some of the things that were similar is, although we didn't have anything that looked like an improvement in ADLs or IADLs, on the mobile clinic, we did have significant changes and improvement in IADLs. And that would involve the patient's executive function. So if you're improving on medications, perhaps that is what we will show our benefit first, even before we see a lot. Another thing that paralleled what we saw in the bus is that we really did have really good benefits in our patients' depression scales. It's very preliminary, but we are quite happy that that did show. We had a quite significant improvement in depression on the mobile nurse managed clinic, plus several other things that I think if we keep doing this, we're going to show some great outcomes. So it's very hopeful. And you are the game changer, ladies, at National Center. We did many things, but until you came along, we really didn't have the kind of support and ability to do what we call intentional teamness development. The facilities thank you. Your team sitting here speaking, we thank you. I want you all to know that there's a great deal of support from our senior leaders, Dr. Julianne Sebastian and Dr. Deli Davies, the Vice Chancellor. The Harder analysis gave us such a nice glowing report. We're embarrassed. We do this for a living. This is a practice-based education model, and so we think we're doing what we do. But apparently this may be helpful to someone else, and we're very happy. And that, just to restate what is the obvious, this is based on a compelling vision, and we are taking ownership of this vision, but to be honest, anybody that works in this setting knows how serious this problem is, and it's all about the patient. That's the end of my talk.
So thank you, Claudia. And we do have several questions that have come in, but what I want to do is, before I take those questions, and actually they're coloring what I'm going to be sharing with you. This was a one-time funding program. We have actually put 6 of the tools that we use up on our website. So the accelerating website, they're readily available, and one is a compelling vision, which we work with many people, not just these 16 sites, to make sure you can communicate and focus the vision. The other thing that I'd like to say is this is a feasibility study. So this was about redesigning practice and education together. And Claudia, I think you and your team are working on scaling it. One of the things I would say is that I cannot say enough about the senior leadership support and the interest in this model. We did do 2 site visits. I was physically on the campus twice. And both times, Dr. Davies and Dr. Sebastian met with me and asked very good questions. The leaders from the 2 facilities attended meetings. So the level of support and interest in this model, particularly as a pilot feasibility, is very high. And taking to the literature on IPE, best evidence medical education reviews show that the grassroots working with the leadership is a critical success factor. That was one of the things that we saw at Nebraska. The other thing, Claudia, I'm going to also observe, and you taught us something, you and your team, is that this team went through pretty amazing unforeseen consequences. There were many things that happened along the way, and those of us who work in interprofessional work are very well aware of the barriers to IPE, and I think your team experienced 85% of them. What that taught us, and what we're now, we've actually put into our information exchange, which we'll be talking about in the future, is how do you track these types of unforeseen events? Because when you need to go, and it happened to you, to talk to your dean about your program, you were able to pull out and talk about, this is my vision, this is what we did, and these were the challenges along the way and what we did to overcome them. So your site taught us a lot. So next, what I'm going to do, Claudia and the team, we have a question, and I have to thank our colleague David Pohl for this one, is he really resonated with your describing a high-functioning team, but ask, is there a specific tool or explicit attributes to assess and focus upon the area of high-functioning teams? And I'm going to answer that first, because the tool that we use and have selected in the National Center, we are developing a core data set, and we used it throughout this particular project, was the ACE-15, Assessing Collaborative Environments. And that is freely available on our website in the measurement section of nexusipe.org. These teams every 6 months filled out those tools, and we particularly were looking at the formation of the team that Claudia described across the organizations. So truly monitoring, talking about your collaboration and functioning is one part of the component. Claudia, I don't know if you have anything to add, and if you, about how you are able to call your team a high-functioning team.
I would say yes. There's a caveat with that. When we were intensely involved in the making of this and working on it, we were really high functioning. The thing about high functioning is a day-to-day operation. You have to stay focused on it. It doesn't just come and land and stay forever. Doing the huddles, I think if you know about team steps, we had a couple of patients that were really critical, things went bad. That's when you can also, that's another place where you can see how high functioning your team is, because you have to make these fast changes to save someone. And that is another way from at the grassroots level, which I really prefer to stay in. One was a lady with a spacer in her hip, and they didn't know how to transfer her. And before we were done, the corporate people were there. I don't know how many people all over came in, because I was on the warpath about how they were not transferring her correctly. And that PT took charge. I love variable leadership, and I explained what she was accountable for. All of a sudden, the whole team revolves around her plan and how you would better transfer what the orthopedic person said. And I won't give you more, but that's how you know. You need to have the broad picture, and you need to measure that ACE-15, that's a very good tool. But when you're in the process of change, you got to look at what's going on around you too.
So that would be the psychological safety factor, is that and we observed that your team was able to talk and function together in a very sophisticated way. I actually have another question. It came in through the chat, which is related, which I think is a great observation. It says, it sounded like you were like a family, and I guess you still are because you're still working together. Any thoughts on extracurricular activities for faculty? And I guess what this person is getting at is, how do you develop the team beyond the workplace?
Well, this team's always got great ideas. A couple of things that I haven't put forward, but this is having an impact on our graduates. That's one place where we see this, they're coming back to be faculty, some of them too. They're interested in this. This is pretty scary if you're an acute care nurse and all of a sudden you look at these discharge plans and they're going, oh, you picked the hard ones, Dr. Chaperone, because that'll help us learn. I said, no, they're all bad. These are information coming from acute care, all look like this. And they're empowered. I need to tell you, they're making some big changes. And I won't bore you with names and places and times, but there's 4 people making some major changes. And they are looking to our college for that. And another place, I really think we have an opportunity to do faculty development. And we have some ideas about that, both within our college and maybe through the NOF group, helping people, GAPNA and other places to get their faculty up to speed on this.
So Claudia and team, there's another question, and it's regarding, would you give some examples on what items you spent your budget? Can an institution use faculty time and salaries to satisfy the required match? And I will actually sort of answer this before I turn it over to you. This was a one-time program. The $50,000 was relatively modest, and that had to be matched. And that was the foundation's vision that we carried out. And so we always tell people, I speak to many provosts and vice presidents of universities, and this is the future. This is now interprofessional work. Having resources to support this work is absolutely critical. So what was so inspiring about these sites is this stimulated innovation that in many of these sites is scaling. And it's scaling up right up to the senior leaders, which was also another requirement, is that when we visited, we asked the PIs to send out letters of invitations to their deans, provosts, vice presidents, and they came. So Claudia, you may talk a little bit about what your specific spend was on the grant. What was the types of things that you spent on the grant?
Well, and this goes back to resources from the top. Honestly, that, and I mean you no disrespect, but that grant didn't pay for faculty salaries to any. We know that that was a small grant, and we had some wonderful support from our dean. I mean, I can't say enough thank yous for that. And I was given time to do more practice and all of that. And I mean, it's just not something that came from your grant. And if it wasn't that kind of support, this couldn't have happened even if we were funded. But the one thing I want to share with people, since they're interested in this, I know that our interprofessional education committee has begun to speak of this, is that we have to have in our university a way of giving time for doing this. I mean, Dr. Sebastian's great, but you know, this is something that we should have this standardized. If your project is XYZ, sustaining something else you were funded for, we have to have money set aside and hours to do it. And I will tell you, we all work quite a bit above our FTE to get it done. That's a fact.
So I'm going to just bring us back to sort of like the sort of closure. And again, we put 6 of these tools up on the website. One of them is the compelling vision that Claudia discussed and her team during this webinar. And the point of these are, we see people get stuck all the time in developing IPE, and we, through experience, are starting to understand the pain points. And so these tools are, when we talk to people, we make visits, it's almost like a diagnostic tool for us because we've seen patterns, and we prescribe them and use them to get people unstuck so that you can continue implementation and keep designing, and particularly with this concept that we've laid out today. So again, these tools are readily available. They're case studies. You'll be hearing journeys and stories over the next several months. You know, we are very happy to answer any questions in the future and keep supporting your work. So I want to thank the Nebraska team for joining us today. They've been very inspiring with their work. And meeting the challenges and seizing opportunities. So thank you so much, Nebraska team, and very appreciative of your participating, everyone in the webinar. Thank you.